Well, welcome everybody. Welcome to another edition of Pasifika Grand Rounds. And today we're going to be talking about long-term follow-up care for childhood cancer survivors. We have our guest that Dr. Samoa is going to introduce here in a little bit. We're going to get through the introductory pieces. So there's a disclaimer we always talk about. The content of this talk and all of PGR talks is provided for informational purposes only and does not intend to substitute professional medical advice, diagnosis, or treatment. PGR is co-sponsored by HAPPY, the Healing Association of Pacific Islanders, Mapu Maya, and Pasifika by Design. We always want to do our land and water acknowledgement first, so I will do the land acknowledgement, and if Dr. Reno Samoa can do the water acknowledgement, we will go from there. So we formally recognize the original stewards of the lands our institutions stand on and their connection to it. The Gabrielino Tongva tribe are recognized as the original inhabitants of these lands, and their absence in this space speaks to the violent history they endured, including their forced relocation, enslavement, and exposure to old world diseases. This led to the rapid collapse of Tongva society ways and their eradication.
We also want to recognize a connection as the Daughters and Sons of Moana. Pacifica Grand Rounds is meant to reflect our roots to the Pacific, but all oceans, and that the ocean connects us and binds us to work together for better days for all our people.
So let's see. So take a moment to record your attendance. And for those of you that need continuing education units, the attendance code for the live session is VEHWOT. You can submit that code via email to cme@coh.org. And we will go over this again before the end of the presentation. I'll turn over to Ray for introductions.
Sure. So we were supposed to have a different moderator. So there's a who had the bio, but I don't need one. I luckily have worked with the wonderful Karla Wilson, nurse practitioner in the Childhood and AYA Survivorship Program, City of Hope, from the very beginning of the program. I've been lucky enough to work the past 15 years alongside with Karla, since a lot of these survivors, as you will see, has endocrinological conditions. So I've been blessed to learn almost everything I know about survivorship programs from Karla. So it's such a treat that we get experience. I think Karla was kind of at the ground level when people didn't even know what survivorship was, to now where it's a mainstay of oncological care. So with no further ado, let me introduce the wonderful, ever ready Karla Wilson.
Thank you very much, Ray.
So we talked earlier. The discussion today is about long-term
follow-up. Something happened with my computer. Oh, there it came
back. So we are going to move into this, and this is, I believe, is Karla's, right?
Yeah, we just have disclosures. I think that's for you, Karla.
I do not have any disclosures. I do not have any disclosures.
Awesome. Nothing to disclose.
Go next. And
so there is a cultural linguistic competency and implicit bias announcement we need to go through, and it's state law. And usually Ray does not read every piece of this, but he does speak a little bit about it before we go into it. Ray, if you want to cover that quickly, and we'll move on.
Sure. It's part of our CME requirements that we have a cultural linguistic competence implicit bias section, or at least is acknowledged when we don't. So the parts that are relevant to this topic is the age consideration when educating regarding late effects of cancer treatment, and the effect of cultural factors on late effects on survivorship.
All right.
Okay.
Go next.
I think we're
ready for you, Karla, now.
All righty. So I did 3 very simple objectives: to demonstrate knowledge of potential risk factors based on treatment, identify some of the common health care issues that they may be at risk for, either currently or in the future, and that can impact their overall general health. Identify resources to improve knowledge of cancer treatment-related risk factors and appropriate screening for those risk factors. And also then to discuss possible barriers and biases which may impact patient care. Next slide. So I always like to start out with giving a little bit of a background by talking about patients to make it somewhat real. So Sally is a 50-year-old woman who was diagnosed at the age of 8 years in 1979. She originally completed treatment in 1981. And then sadly, she relapsed as actually a late relapse. She was almost 9 years post-treatment when she had her first relapse. She completed treatment again, but then a few months after her second treatment, she relapsed again. And as you can see, she had a lot of different chemotherapy agents. She had a lot of treatment in general. She had radiation to her craniospinal location, and she had 2400 centigrade. If she were being diagnosed today and needed radiation, she wouldn't get it to her spine. She would only have it to her cranium, and she would have half the dose of radiation. But then because she relapsed twice and had a bone marrow transplant, she had total body radiation when she was 22. So it actually gave her a cumulative craniospinal radiation dose of 3480 centigrade, which is a relatively high dose for someone. She did have a hematopoietic stem cell transplant, and she had a match-related donor, and that was done in 1992. Then, oh, it's letting me move forward, I think. Adam is currently 38. He was diagnosed about 9 years after Sally when he was 4 years old, and he completed treatment in 1990. As you can see listed here, he had a lot less chemotherapy agents. He had no radiation, and he did not have a transplant. What is interesting, though, about Adam is he had an identical twin brother who was also diagnosed with ALL and actually died within days of Adam completing his therapy. So I just kind of start out with those patients to kind of make what we're talking about a little bit more real. And we will come back and talk about those patients again at the very end. So the things with the cancer specifics are just general information regarding the global impact of cancer. There are approximately 20 million people currently being diagnosed with cancer each year in the world, slightly higher incidence in males compared to females. And if we look at childhood and adolescent and young adult cancers, there are about 1 million AYAs and about 400,000 children. The definition of childhood cancer is basically children are less than 22 years of age at the time of diagnosis. Adolescents and young adults are between the ages of 15 and 39. So there's a little bit of an overlap of those late teenage years. The types of cancers do vary by what's the most common type around the world. Of interest, there are about 23 countries that cervical cancer is the most common cancer in those countries. Then looking at the types of cancers, not the types of cancer, the estimated number of cancers throughout the world, you can see by this map. And if you look at the different numbers, you can see, for example, the United States and Canada, considered North America, have almost 2 million new cancer diagnoses each year, where you might see like in Southern Africa, there's only a little over 100,000. So there are certainly different incidents around the world, and it's somewhat related to larger population, more likely to have a larger incidence of cancer. We can go up. So what are the causes? There's a lot thought to be related to environmental issues, such as physical causes, chemical carcinogens. There's biologic causes, such as viruses, bacteria, parasites, and there's the huge category of unknown. And that's particularly true in childhood cancers. For most childhood cancers, we do not have any kind of definitive cause. The next few lines give an idea of what are the cancer occurrences by type. And in general, breast cancer is the most common type of cancer worldwide, followed by lung cancer. That actually used to be the opposite. Lung cancer was the most common, but as smoking has decreased in many populations, the incidence of lung cancer has also gone down. There are also cancers that are associated with infections such as HPV, H. pylori, EBV, HIV, and hepatitis. And those are thought to make up about a third of all the cancers that occur in low and lower middle income countries. We know that cancer is generally the first or second leading cause of death by disease in many countries. Overall, heart disease is often the first. In 2020, there were 10 million deaths associated with cancer, and that accounts to 1 in 6 deaths by disease. And that's probably an underreported number because depending upon the country, some of these things are not really well identified in data. It is thought, though, that a third of all cancer deaths are associated with things like tobacco use, high alcohol consumption, lack of physical activity, a high BMI, and low fruit and vegetable intake. So what is cancer survivorship? There are kind of a few different definitions. The National Coalition of Cancer Survivors says it's basically you're a survivor from the time you're diagnosed and as long as you are alive. And they, in their definition, also include family members, friends, and caregivers, because cancer is really not a disease of an individual. It's a disease of a family and a community. But one of the things that I think is extremely important about survivorship statistics, when we talk about survivors, we're only really referring, are they alive? Or are they not alive? And it does not take into any consideration what is the quality of life that that survivor has. There are approximately 44 million survivors that have been diagnosed within the last 5 years. The highest survival rates tend to be in developed countries such as the United States, Canada, Australia, New Zealand, and the Nordic countries of Western Europe. There are specific cancer survivor rates that may vary among countries. I thought it was very interesting. GI cancers in Asian countries tend to have a higher survival rate compared to some of the other countries, but they actually have a lower survival rate for melanoma. So there's idiosyncrasies between different countries. We do know, though, that survivor trends are increasing in most of the world. In general, the incidence of survivorship has tripled in most countries since 1970. And there are approximately 70% of cancer survivors that are greater than 5 years from diagnosis, 47% that are 10 years out, and 18% that are 20 plus years out. About 2/3 of all cancer survivors are at least 65 years of age or greater, and about 1/3 are less than 65. But we do know that there are approximately 8 million cancer survivors that are living with some form of disability secondary to their cancer or their cancer treatment. And this map just gives you an idea of where cancer survivors are the greatest. So the darker the color, the greater number of cancer survivors. The lighter the color, the less number of cancer survivors in that country. And as you can see, the greatest number of cancer survivors tend to be in developed countries and less in lower and low middle income countries. And this, again, is just another map that tells you what cancer survivorship has been happening since 1975 and where it is projected to be in 2040. And this particular slide is really only counting the data in the United States. So currently, we are about 18 million cancer survivors. And it is thought by 2040, we will have about 26 million in the United States. And the different colors have to do with ages. And since there are lower incidence of cancer in younger people, you're going to have a lower number of survivors in in that age range. And cancer really tends to be more of a disease of the elderly. The vast majority of cancers occur in people, obviously over the age of 40, but even greater incidence over the age of 60 and onward. Go ahead. So survivorship started being talked about in the late 1970s because we were making progress on childhood cancer survivorship. And there was actually a radiation oncologist at Children's Hospital of Philadelphia who was one of the first people to really talk about this and saying, now that we're curing these kids, we need to look at how we're curing them. And the first book I ever remember seeing was the Damocles syndrome. And it was actually written by two psychologists, or a psychologist and a physician. And they really focus on what are the psychosocial aspects for childhood cancer survivors. And that was what, I have to be honest, was the first thing that interested me in survivorship. And I still have that book that I bought in 1981. In 2000, we started seeing more survivorship books come out. Childhood Cancer Survivors was actually written by a mother of a childhood cancer survivor and two nurses who are leaders in the childhood cancer survivorship world. And this book was really geared for patients and family members. And then in 2003, the Children's Oncology Group came up with the long-term follow-up guidelines telling us, how do we screen people? What matters? And the long-term follow-up guidelines are really based on evidence and research. They're not totally research-based because we don't have enough research yet. And I'm happy to say that version 6 came out last week. So we now have new guidelines. Many things have not changed, but they always update changes based on new evidence and new research that has come out. But in 2005, the Institute of Medicine really mandated that something needed to be done about cancer survivorship. And one of the things they said is, Carl, you can move to the next slide. Oh, where's the other? I think it skipped one. Could you go back? Yeah, I'm missing the slide. Okay, go ahead and go forward. But one of the things that and you can go forward. One of the things they said, there are things that we really need to look at, and that programs need to consider survivorship an important component of care. And it's not just the actual treatment that's important. Kevin Elfinger, who wrote this quote, is actually a primary care doctor who originally was at Sloan Kettering and worked in the survivorship program. He has since relocated, and I'm blanking where he went. But he said that the cancer experience is a process that extends throughout a lifetime. And it's really a looking glass that all future health and illness behaviors of the survivor must be interpreted. We have to figure out, is the current issue that the patient is having, is it related to their cancer history, or is it not related? So that's a really key component of providing care for these people. Next. So I guess there's no animation, right, Carl? So anyway, the cancer survivorship, this slide was to tell you about different components of survivorship that are important and what we really need to look at for long-term follow-up care. And to be honest, cancer survivorship is really the tip of the iceberg. We think about cancer, but it's all the things that happen after cancer and cancer treatment that really kind of tell what is going to happen to this patient as they age. And how are they going to respond to that impact they've had in their life? And is it going to influence their future health and their future behaviors? Next quote. So what is a definition of late effect? And the classic definition is that these are health complications either persist or arise following the completion of cancer treatment. And we know these health conditions can influence both the survivor's quality and quantity of life. There are some key factors that can impact We know gender makes a difference. There are certain late effects that are more common in females compared to males, especially related to psychosocial. There are more psychosocial issues in female survivors compared to their male counterparts. What was their age when they were treated, and what's their current age? Depending upon treatment, some treatments can cause a risk for greater late effects when a person is younger. For example, if a child is radiated at the age of 3 or 4 for cranial radiation, that can really have an impact on their cognitive health and growth. If they have physical radiation, say, for example, a 12-year-old girl who gets chest radiation for Hodgkin's disease, she might not have normal breast maturation or development. And then there are things that are really important, like what's the cumulative dose? What's the intensity? Do they have complications of therapy? I have a patient that I've been following for years. She had what was called low-risk ALL, but she ended up having profound neutropenia, got extremely sick, ended up with aspergillosis pneumonia, and ended up having half of one lung removed. So she's got a risk factor for pulmonary problems that you would not normally expect in someone who had her treatment. And then when we think about surgery and radiation, what part of the body was impacted? Because that also, of course, will lead to different problems with, as particularly in children as they grow. How was their psychological coping when they were being treated? What type of support did they have? Do they have comorbidities? What's their current health-related behaviors? Do they have a healthy diet? Are they exercising? Are they smoking? Are they using alcohol? Are they using illicit drugs, etc.? And so we really know that late effects are multifactorial. The treatment's important, the treatment events, as I mentioned. What was the type of tumor? What were their precancer conditions? Do they have any genetic factors? What are their health behaviors? And all of those can impact and help to qualify what type of late effects a patient may be at risk for. Go ahead. So we think about the cost of cure. So when we look at morbidity, we know based on the childhood cancer survivorship study that approximately 95% of all cancer survivors will have at least one significant health event by the age of 45 years. That can be related to the actual cancer, or it can be related to a side effect or a result of treatment. And 30 years post-treatment, about 73% will have greater or equal to one chronic health condition that can be either mild to severe. And about 42% will have had a severe or a life-threatening health condition. And then when we think about mortality, 35% of childhood cancer survivors die within 30 years of their original cancer diagnosis. 17% die within about 5 years of diagnosis, and then the 18% are greater than 5 years. And based from the childhood cancer survivorship study, which actually used the siblings of childhood cancer patients as the control, about 8 childhood cancer survivors, about 8 times more likely to have a severe or life-threatening health condition compared to their sibling. Some of the issues that we see are related to their physical health, chronic fatigue. They may have organ disease. Endocrinopathies are a very large late effect that occurs. They may have sexual dysfunction issues. They may have, related to sexual dysfunction, they may have delayed puberty. They may only be able to go through puberty with hormone therapy. They may have low libido, etc. They may have post-surgical changes. That can be anywhere from amputations to limb salvage to ostomies, etc. And then there's always the risk of cancer recurrences or second malignant neoplasms. The emotional burden is related to the fear of reoccurrence and higher incidence possibly of social isolation. A lot of cancer survivors have relationship problems, either with their peers or with romantic partners. As many of my young adult patients say to me, I just started dating someone. Do I tell them that I had cancer? When do I tell them? If it's a patient who's a cancer survivor, my screen went totally black. Are you still there?
Yep, we're still here.
Let me see if I can get it back up.
Uh,
Oh, thankfully it came back.
okay.
I don't know what happened. Um, then there are social issues. And of course, in the United States, we have different issues than many other countries because we have all of the issues related to insurance being connected to your job or your parents' job. In 2010, the Affordable Care Act came about, and that actually eliminated penalties for pre-existing conditions. So patients now can get health insurance where prior to 2010, they might not be able to get it. They still may not be able to get things like life insurance. We know that many patients have problems with school or work performance. We also know it can be a huge impact on family members and caregiver burden, particularly if it is a cancer survivor who has had multiple relapses. They're chronically on treatment, or cancer survivors, for example, of a child who had a brain tumor that has pretty significant neurological problems and will never be able to live independently. And there are spiritual issues as well. And the thought of, why me? Why did it happen to me? I'm a good person. I go to church. Why did God do this to me? And we often have patients who question these issues all the time. And unfortunately, this slide was animated, so you can read a little bit about what is there. In children in particularly, we think about growth and development. Are they their linear growth? What's their skeletal maturation? What's their intellectual function? What's their emotional and social maturation? What's their sexual health like? And we often see in young children, they may not do very well with their peers, but they're great at interacting with adults, particularly children that are hospitalized for long, long periods of time, because they're interacting more with adults than they are with their peers. In all patients, regardless of their age, there are risk factors for things like cardiac issues, pulmonary issues, so basically vital organ functions. Some patients have risk of fertility and reproduction. They may have decreased hormone levels and hypogonadism. Women may go into premature ovarian failure and premature menopause. But one thing that we have found that in general, the offspring of cancer survivors are no greater risk of getting cancer than the offspring of people in the general population. There are some specific caveats. That's not true for if it's a genetic related disease or a genetic syndrome, or if they have something like P51 or Lee-Fermani syndrome. And there are patients who also develop second tumors, whether they're benign or malignant. And this slide just talks about when you look at adults without cancer who are the lighter color and cancer survivors, when you look at physical health, there's a pretty significant difference in physical health between the adults without cancer compared to the ones with. When you look at mental health, there's a little bit less of a discrepancy between the two groups. But when you combine physical and mental health together, there's even less of a discrepancy. But in general, cancer survivors always have a greater impact on their physical and mental health. So next slide. So these next slides are just charts. I put them in basically by system. So things to think about if you're looking at the central nervous system or the peripheral nervous system, what are potential late effects? It can be things like seizures, neuropathies, neurocognitive deficits, second malignant neoplasm, such as a brain tumor and somebody's had radiation. So the exposure is the treatment. So it can be surgery, it can be chemotherapy. Specific chemotherapies are associated with specific late effects. Endocrine patients might have growth hormone deficits, either hyper or hypothyroidism, although hypothyroidism is the more common. They might have thyroid nodules that are either benign or malignant, and those are all related to radiation therapy, to the brain or to the neck. Next slide. When we think about the head, patients who have radiation therapy and certain chemotherapy agents such as busulfan and steroids can cause premature cataracts. They may have ototoxicity if they have cranial radiation, or have cisplatin or platinum category of chemotherapy agents. But another area that can actually affect hearing is if they receive aminoglycoside antibiotics or they get IV push Lasix. Both of those agents can cause an impact to the eighth cranial nerve and affect hearing. They may have dental problems related to either radiation or chemotherapy. And a very common problem patients have who have had cranial radiation or total body radiation is extreme dry eyes, to the point that they always look like they've been crying for hours because they have red irritated eyes. They might have pulmonary issues, again, related to radiation, but also to some specific chemotherapy agents. Next slide. Cardiac issues we tend to think of related to the anthracycline category of chemotherapies, but we also have cardiac issues related to chest radiation or total body radiation, and those can include valve disease as well as carotid artery disease. And then radiation is kind of the gift that keeps on giving, and we see a higher incidence of things like colon cancer in people who had abdominal radiation. We see esophageal strictures in people who had chest or neck radiation, and also patients who have chronic graft versus host disease following bone marrow transplant may have strictures as well. They can also have things like fistulas and bowel obstruction associated with radiation, and they can have hepatic toxicity from many things, including chronic graft versus host disease, specific chemotherapy agents like 6-mercaptopurine or methotrexate, but also blood products. Although in today's day and age, a patient is less likely to have an impact from blood products, but patients who were treated in the 70s and the 80s up into the mid-90s were at high risk for things like HIV, hepatitis C in particular. Now that we have testing for those agents, we're not seeing as many people with those types of late effects. Bladder and renal toxicity can be associated also with certain chemotherapy agents, particularly ifosfamide and platinum drugs. Antifungal agents, since vancomycin, put people at greater risk for renal toxicity, as well as immune suppression agents used for graft versus host disease. Cyclophosphamide is associated with bladder malignancy, and both cyclophosphamide and ifosfamide are associated with hemorrhagic cystitis, although I'm happy to say that, again, is less common now than it was 20 to 30 years ago. We do see reproductive issues, as I mentioned before, including sexual dysfunction. But another thing that we see is uterine insufficiency. If a female has radiation to her abdomen, and it doesn't matter what age she had it, she could have been a young child or she could be a teenager, it can cause the uterus to lose its ability to expand. I have one patient that I've been seeing pretty much since our program started, and she's actually 70 now. She was treated at 1 year of age for Wilms tumor, and at the time she was treated in 1954, the only treatment was surgical removal of the kidney followed by radiation therapy. Well, the radiation therapy basically hit one side of her abdomen, so she actually had one ovary that functioned normally, but she had 7 miscarriages, and no one knew or understood why she kept miscarrying. And she told me that she always miscarried between 10 and 13 weeks of pregnancy. And it was when she came to survivorship clinic that I told her the reason she miscarried was that radiation she had as a 1-year-old. She actually started crying because she was so relieved to know that the reason she miscarried had nothing to do with anything she was doing. It was from something that had happened to her as a young child that was totally out of her control. So sometimes when I see survivorship patients and we can tell them why they have a certain problem, it's almost a sense of relief to them to have that identified. Next slide. There are musculoskeletal issues such as avascular necrosis that can be from steroids or from radiation therapy. Reduced bone marrow density is most commonly related to steroids and transplant. We do see bone changes, again, because of radiation therapy. Skin changes can be related to certain chemotherapy agents causing permanent discoloration or striae. We do have patients with cranial radiation that have permanent alopecia. They may frequently develop skin cancers, and those who have chronic graft versus host disease actually can develop scleroderma-like changes that unfortunately do not respond to any of the normal treatments for people who have scleroderma unrelated to graft versus host disease. We do see lymphomas in patients following therapy. It can be a lymphoproliferative disorder. They may be at risk for chronic or life-threatening infection because they had their spleen removed, or they have chronic graft versus host disease and they cannot mount a normal immune response. We see second malignant neoplasms, primarily AML and myelodysplastic syndrome from alkylating agents. And we see a lot of metabolic disorders, primarily related to radiation to the abdomen or total body radiation. And this is where endocrinology really comes in. We have a lot of patients with dyslipidemia, patients who are either pre-diabetic or who have developed diabetes. We see a higher incidence of people who are obese or overweight, and we see a higher incidence of metabolic syndrome that can be accounted related to the radiation that they've had. There are chronic psychosocial issues, fatigue, chronic pain, post-traumatic stress disorder, or post-traumatic stress syndrome. There's, again, social isolation. You do have some patients who participate in risky behaviors because they think, oh, I survived cancer, or I can do anything, I'm invulnerable. We do see some higher incidence of mental health disorders and issues with both school and work. Again, I mentioned that we have second malignant neoplasms, and not so common. We do have things like they can get infections related to a retained cuff from their central line or their line tract. And not long ago, I had a patient who no longer lives in Southern California, but she had told her primary care doctor where she had moved to that we had recommended that she have mammograms starting at age 25 because of her history of chest radiation. Well, she had this abnormality on her mammogram and they couldn't identify it. And she ended up having a biopsy. And it turned out that it was part of her central line that had migrated and had gotten encapsulated in her breast tissue. But she was scared to death that she was going to have breast cancer. And it turned out to be, fortunately, something that was very unusual. And it's the only time I've seen that in my career. But I always say, no matter how long you do something, you always see something new. So some therapies are based on the patient either had the therapy or they didn't. Other therapies are dose specific, higher dose, greater risk. For some types of chemo, it's a single dose that is important versus the cumulative dose. And we also know that some late effects, particularly related to the central nervous system, it can be related to the route. So you can give a patient IV or oral methotrexate, and it won't cause cognitive impairment. But you can give methotrexate via the intrathecal route and directly into their spinal fluid, and that puts them at greater risk for cognitive impairments. Next slide. So what does long-term follow-up care involve? The IOM report really talked about, I think they had 10 main recommendations, but the three that to me are the most important are that it is a distinct phase of cancer treatment. It's important to provide a comprehensive care summary, and it's important that that summary be shared with the patient and with the patient's other caregivers. And they really recommended to all of the oncology folks that you need to develop both evidence-based guidelines as well as research-based guidelines, and that we need to have assessment tools and screening instruments so that we can identify and then manage late effects of treatment. And this types of things are extremely important to a patient's long-term health. And actually, for a institution to be designated as an NCI cancer center, they have to have a survivorship program as part of their program. Next slide. And there's been a lot of buzz in the last probably 10 years about something called survivorship care plans. And you can go to a lot of the patient websites and the advocacy websites like Livestrong and others. And they talk about you really need a care plan. You need to have knowledge of what you were treated. And so basically a care plan summarizes their cancer treatment and whether they had significant complications. But it's really important that the team be the survivor, the primary care providers, as well as the specialists and the oncology. And it's really important to have coordination of care and their health surveillance. I have a lot of patients that have come to me and say, oh, my healthcare provider told me I need to do, XYZ. Well, they really don't need to do XYZ because they didn't have treatment that puts them at greater risk. For some things, they're going to have the same risk as the general population, and other things they're going to have a greater risk. And so that's why it's so important to have these teams and to have this, that the patient be an advocate for themselves and to really understand that they need to have a coordination of care and that they should be having screenings based on the known guidelines. Next slide. So these guidelines can really tell us what is best for a patient. So for example, if women have chest radiation, we know that they should start getting breast cancer screening at age 25 years of age or 8 years after the radiation, whichever occurs last. We know the same thing about colon cancer. If they have abdominal radiation, it's age 30 or 5 years after radiation, again, whatever occurs last. We need to really focus on general health promotion, and they should be doing all the routine screening things for cancer and other health conditions that you would do for any patient. And it's important to provide this education to patients. There are a lot of challenges, though. Who does the summary? How do the patients get it? What model should you use, et cetera? How do you implement it? How do you get insurance to pay for things? Insurance typically balks when you order a mammogram for a 25-year-old woman. How do we reach minorities? What about patients who don't read? A lot of our information is in English. Although I will say in the Children's Oncology Group, we now have a lot of education materials for patients in Spanish, French, and Mandarin. And then we need to figure out how do we make the care of a cancer survivor a part of standard of practice and have all of the members of the team, including the patient and the family, understand what is important for their long-term health care. So I like to tell patients that these are some of the things you can do for healthy living. You need to have a PCP. You need to have dental and vision care. You need to keep your treatment summary. You need to share it with people. You need to have normal well checkups with your PCP. You need to have healthy lifestyle practices, such as nutrition, exercise, practice safe sex, wear things like sunscreen, helmets, seatbelts, get your immunizations, don't smoke, don't drink in excess, etc. Basically everything you would tell any patient. But I think it's just really important to stress these things to the cancer survivor. Next slide. So what are some of the tips that I can give to primary care people? Try to make sure that your patient your patient's a cancer survivor. Ask them, do you have a summary that tells what your treatment was? There are screening recommendations that are open to the general public, including the Children's Oncology Group long-term follow-up guidelines. ASCO and ASH have both developed some guidelines as well for following up with patients. And really try to empower patients and have them be advocates for themselves. Next slide. So a lot of questions we get is, how long should a patient follow up with an oncology team? Well, that varies from place to place. In general, childhood cancer survivors stay with the oncologist until they're 21. Then they go to the long-term follow-up team, 2 years off of therapy, and they may stay with that long-term follow-up team indefinitely if they are at a cancer center. If they're at a children's hospital, they typically age out at age 21. Again, in the adult world, it varies depending upon the institution, the oncologist, the type of disease, what are the program standards, do they have residual problems such as chronic graft versus host disease. In general, patients start seeing a long-term follow-up team, such as we have here at City of Hope, when they are 2 years following completion of all cancer-directed therapy. They may still be getting supportive care, such as a patient who had a bone marrow transplant might still be on immune suppressant therapy, but they are not getting active cancer treatment and they are in remission. There's no consistent standard for how PCPs monitor, and so a lot of education needs to be done. And unfortunately, in the United States, insurance is often the dictator of how long-term follow-up treatment is done for patients. This is just a link to the childhood or the Children's Oncology Group long-term follow-up guidelines. It is a public website. It's at www.survivorshipguidelines.org. And as I said, version 6 actually came out last week. The National Comprehensive Cancer Network has also developed survivorship guidelines as well. And they have guidelines associated with physical health behaviors, etc. And that also can be accessed via their website, which is nccn.org. Next. ASCO has some mottos for survivorship care, and they have information for education, both provider and for education for survivors and families. And they are doing a lot of policy and advocacy and research as well. And so one of the themes that we want to think about in long-term follow-up care is really empowering patients. You know, it used to be that the physician was the all-powerful one, but it's really transitioning now to share that ownership, and you want to have patients that are empowered. And when patients are empowered, they tend to be more adherent, they tend to do better healthcare management, and etc. So it can be a win-win for everyone. Next slide. So back to those two patients. So just as you go to the next slide, as a recap, Sally had a significant amount of treatment. Next slide. Adam had minimal treatment. And then let's look at Sally's late effects. So she has late effects that started in 1999 and she has a significant number of endocrine late effects: hypothyroidism, dyslipidemia, metabolic syndrome, type 2 diabetes. She's had hypertension, hypomagnesemia. She originally had grade 3 renal disease that started in about 2011. And I talked to her just a few weeks ago, and she's now on dialysis for end-stage renal disease. She had premature ovarian failure, infertility. She has depression issues, decreased speed of processing, short-term memory, osteopenia for musculoskeletal. She's had meningioma as a, quote, benign brain tumor, and she's had multiple basal cell skin cancers. She's had cataracts from her radiation. She has peripheral neuropathy, permanent alopecia from her radiation. In the 1990s, she had a lot of risky behaviors, including drug and alcohol use. She's had debilitating fatigue since 2006. She did not have insurance till 2007, and I actually got her charity care here at City of Hope. And then when the Affordable Care Act came out, she has insurance through that. And then Adam had no identified late effects. And so this really just shows you that the heavier the treatment, the greater risk. Julie Rowland was the head of the NCI cancer survivorship arena. And she says cancer is often a life-altering and potentially traumatic effect, but we can make recovery easier by educating survivors on what to expect, giving them ways to manage stress, teaching them effective behavioral and coping skills, and directing them to resources that can help them not merely survive, but hopefully thrive after treatment. And does anyone have any questions? Because my screen went black again. Let me see if I can get it back on.
Well, we'll let people who are viewing in on the streaming sites feel free to drop your question into the chat. I don't know if you can see them, Carl, if they do come in.
We haven't gotten any questions from the audience. A lot of our audience is post airing, right? We don't have a huge live audience, but being a cancer survivor myself, there were several things that stood out. So thank you, Karla, so much for sharing the information. A lot of that makes sense, and then there's pieces of it that kind of has me at least scratching my head. One of the things that I noticed is that it's to me interesting to see the trying to join the patient and the physician on the journey. It seemed more directed early on with cancer treatment. Is that something that you see personally as advice and direction, or are you seeing that in the industry where the patients are becoming more educated and being more of an advocate and partner with the physician?
It's probably a combination. We certainly see people of different ethnicities having maybe certain behaviors. We also see people of different socioeconomic areas. I still, to this day and age, will work with patients who will nod their heads and agree with everything I say because they look at me as if someone in authority. And then I have patients who are so motivated, so into what do I need to know? What do I need to have as my healthy standard? How do I do this? How do I do that? I personally think that patients who really advocate to themselves tend to have a better collegial relationship with their healthcare provider versus patients who are yes, no type of people. And when I say that you see differences in certain ethnicities, that's a general statement because it's the individual and how they are. I have people who someone will say, oh, well, they're this ethnicity, so they're going to do it this way. Well, that's not true. That may be that in general, that ethnic group tends to be that way, but the individual patient tends not to be. But I think the better you educate, the more you involve and you try to get that patient to feel like they are an active partner on the team, you're going to have patients who are going to have a better existence. They're going to be happier. They're going to be healthier. And when I look at the patients, I'm amazed at what some patients accomplish in spite of what's going on with their health. I recently had contact with a young woman who had a brain tumor that recurred at the same time that she developed myelodysplastic syndrome that merged into acute myeloid leukemia. And she was getting a bone marrow transplant. And her biggest concern weren't all the side effects of what was going to happen to her in transplant, but could she keep up with her classes because she wanted to graduate on time from college. And I found that young woman just to be amazing. So it's the individual. You can certainly take cues from someone's ethnic background at times, and Ray might be able to answer this because he and I have worked together for a long time, and he's really, I think, don't you agree, Ray, that talking to patients and trying to get them to take responsibility for themselves increases their functionality?
Oh yeah, absolutely. I think the what you said about like early engagement helps reduce a lot of the at least metabolic late effects that come with cancer survivors. And it's one may look at sort of kind of the late effects and oh well, they're at high risk for diabetes, um but they're in a high risk group for diabetes anyway.
Mm-hmm.
This is a different type of diabetes sometimes. Like we're talking like, you know, really bad diabetes at a younger age. A lot of times with these cancer survivors, you know, and it's there. Some of the treatments, uh, you know, just causes this really bad metabolic shift on top of sort of what their you know, risks that we get from their socioeconomic conditions, and just compounds it. You know. Um,
We used to not start seeing the patients in the survivorship program until they were 5 years from diagnosis. They had to be at least 2 years off treatment, but 5 years from diagnosis. Well, over the years, cancer treatments have changed. A lot. There are, for certain cancers, they might get 3 months of treatment, or they might get 6 months, or 9 months, or a year. Most patients who don't relapse, other than kids with ALL, acute lymphoblastic leukemia, they typically get 2 to 3 years of treatment because of their maintenance therapy. But most other patients, they are done with treatment before a year is up. And so we switched that. We only made it 2 years off treatment so that we could engage them sooner, because what 15-year-old cares about learning about cancer if their first exposure to the late effects program is, you know, when they're 20, they're past it. And so the sooner we can then engage them about risk factors related to their cancer treatment and why their lifestyle choices can really direct what can happen to their health as they age. I think it's just really important to get people engaged sooner versus later.
So we're definitely in the information age. There is information everywhere, and I think the internet has made the transfer of information much faster, but it's also made the transfer of misinformation greater
Yes.
as well. So, in your opinion, with patients becoming more educated and becoming more of a partner with the physician, is there an issue with misinformation out there where, you know, people want to diagnose through Google MD and decide what's best for them? You know what I mean? Or look at the comment section in social media for how they should treat their cancer or things they should do. Is the net effect, do you think, still positive that people are partnering with their physician? Or do you run into, or have you seen your industry run into legitimate issues where people have gotten, you know, misinformation and tried to act upon it?
Absolutely. And so one of the things that we do in our program is I've over the years have put together a resource file, and we update those resource files regularly. And I'll tell patients the internet can be great, but you need to make sure the source on the internet that you're looking at is a reliable resource. So I'll give them list of, you know, if it's from this place, it may be good. If it's from this place, and anything that you have a question about, please shoot me an email or message in the portal to say, what do you think about this? Because there are some amazing information sites out there. And I try to, especially as you said, in this day of Medium, so many patients, they don't want paper stuff. They want links to a website or links to that. And one of the things that it's really happened it's always kind of happened, but it seems to be happening even more now. There are some really good patient advocacy groups out there. Livestrong has some amazing resources. There's an organization called Stupid Cancer that was started by a guy who was 22, his last year of college when he developed a brain tumor. And they have some really terrific information and webinars. There are different camps and programs, not just for individuals, but also for a lot of times for the family members of the patient, which can be really important too, because you really need to educate the whole family or the whole patient's community. And by family, I don't necessarily mean a blood relative, but who that person considers to be family. We encourage our patients to have someone come with them to clinic, whether it be their partner, their parent, their spouse, their best friend, whatever. Because I think the more people who learn and the more information that is given, you get a ripple effect by increasing knowledge.
Is it? And you both work at City of Hope, and it's one of the first things that my wife is a scientist of sorts, and she's big into research. And when she heard that that Ray worked at the City of Hope, she was like, "That's one of the institutions." I see the picture in the slide, the 41st annual bone marrow transplant reunion, and all of the amazing things that go on at the City of Hope. Um, do are there facilities that are ahead or behind? You know what I mean? They're kind of the tip of the spear in terms of treatment or research or those kind of things. And I know that my wife considers City of Hope one of those. Are there? So I guess you would give that information out to patients, right? Like which facilities and which institutions, which website links, and those kind of things are reputable. Is that when you say you're giving that information out? Is that what you're kind of trying to do?
Yeah, I mean, my big focus is pediatrics and pediatric oncology. So I know a lot more about that than I do the adult world, other than AYAs. But one of the things I tell patients, you could go, anyone that has who is in the children's oncology group, we're using the same treatments, the same protocols, etc. I would not recommend for a parent to take their child to someone who's not part of COG, because they may not be getting the best therapy. And in pediatrics, most places are COG. The adult world, I think, is probably what's a little more iffy, in that you might have people not connected with cancer centers who maybe don't know the most cutting edge treatment or the newest therapies out there. And I'm probably biased, because I really feel that being treated at a center that, for example, my previous specialty before I came to survivorship was working with kids with neurotumors. And there was research data to show that those kids who were treated at a program that had a pediatric neuro-oncology program had a higher survival rate and a better quality of life than children who were not treated at a center that had specific neuro-oncology people.
Yeah, and in the adult world, the childhood survivorship programs were the model that now all these survivorship programs are kind of like following. So now you have breast cancer survivorship, you have adult hematology, and hematological malignancies survivorship, you have bone marrow transplant survivorship. So there's, out of like all the work that's been done at the childhood and AYA demographic, you're starting to see these roll out. And one of the places where I see it's is kind of useful is when patients get their oncological care from the community, like a community oncologist instead of like a tertiary cancer center. They can get, I think they get well treated and cared for during the actual time they're fighting the cancer. Where things get kind of murky is survivorship, right? Because it can be kind of overwhelming for a community oncologist not only to do just their regular oncology care, but to do a survivorship program takes a lot of effort on its own. One example can be is that with breast cancer, weight gain is a huge risk factor for recurrence. And but weight gain is so common. Right, it's so common with breast cancer treatment, and that part of survivorship now I think is starting to sort of bring that to light. One thing about sort of breast cancer survivorship is there's medications they use after someone's completed therapy to help keep the cancer away. It's like it's what do you call it, Karla?
Preventive.
Yeah, it's kind of preventive to prevent recurrence, but it's hormonal therapy that can kind of wreak havoc on your metabolism, and what some of these studies are showing is that eating healthier and exercising to keep your weight down actually is a better it's more effective than this preventive chemotherapy. And so that's the power of survivorship in a lot of these adult conditions, in regards to recurrence. And I think there's also data in children too that shows that obesity and weight gain is also a risk factor for recurrence. And so, the survivorship not only sort of surveys to make sure that the primary cancer doesn't come back, but also minimizes the risk factors that can cause a recurrence too. These are important things. And that's going to take a lot of education on the community part, that like there's so much of keeping the cancer away and fighting cancer that can come from how we live our lives. And how we live our lives, as Carl can tell you, Carla, is heavily dependent on how we interact with our communities and what is our standard, like what is normal for our community. And so I think the point you made about finding a primary care provider, oh, that's unbelievably solid. But I think on top of just identifying a primary care provider, providing these community support programs that help prevent diabetes, that are kind of run through community health workers and community-based organizations, that broadens the reach of these survivorship programs. And I would love to see, those groups collaborate a little more. All right. I think, we're over, but we're over, but never done.
I think we have.
I want to thank Karla Wilson once again for her wonderful, informative talk. These Pacifica Grand Rounds are recorded, and can be viewed later. Carl, what's the channel called?
So it's on YouTube on Pasifika by Design, at Pasifika by Design, as well as Facebook, and we will link that in the comments. So don't forget, this is only for the live attendance to get your CMEs. And so the code is VEHWOT. Submit that code to CME at coh.org to get that. And then last piece is we're always going to talk about our next show. Pasifika Grand Rounds is every third Tuesday of the month at 5:30 p.m. Pacific. So I think that puts us at January 16th. Next year, I don't know the topic. Ray, do you know the topic offhand?
I do. It's healthcare. It's bias in hospitalized medicine.
So bias in hospitalized medicine. That is January 16th. We'll look to see you there. Thank you so much, Karla Wilson, for joining us.
Thank you.
I'm going to sign us off.
For the CME, if you haven't signed up and gotten registered for an account with City of Hope for your CME credit, that's okay. If you just email the code to the CME office, they'll get you started that way. So don't worry if you haven't registered yet.
You can do it backwards. You can get the CME and then register after, but just start the process. I guess that's the main thing is send it to the email, then we can work it out.
Okay. Awesome.
All right. Thank you so much.
Karla.
All right. Thank you, and happy holidays to all.
Happy holidays, everyone.
Bye-bye.